What I'd like to talk about during this session is some of the challenges that have faced us as an international medical assistance organization trying to help patients overseas during the crisis. I'd like to talk a little bit about our approach to case management for COVID-19 patients. And in particular, I want to then focus on a lot of the difficulties that we've had to deal with in affecting air ambulance evacuations from different locations around the world. And then to finish, I'll just talk a little bit about risk mitigation. So COVID-19 has caused us a great deal of problems over the past year and a bit, and not least because it's actually a very difficult disease to deal with if you're an international medical assistance organization. Of course, it is a two-stage illness, isn't it? Where everyone gets the first stage, which is the mild stage. Fortunately, nearly everyone gets better after that, but we know that a small number of patients go on to develop the severe second stage. Those are the ones that end up in hospital, and some of those patients die. What is difficult is that moving from stage 1, where you're relatively well, to stage 2, that clinical deterioration, can be remarkably rapid. And what's even worse is that patients' clinical symptoms often don't correlate with their physiological deterioration. So patients can get extremely unwell without the symptoms that you would expect. And that's tricky if you're trying to monitor patients remotely and get an idea down the phone of how they are. And the final challenge is that patients who need treatment for severe COVID need care that goes, what I've written there is beyond the referral hospital. And what I mean by that is that when we deal with cases abroad that we're worried about, we like to transfer them to what we call a center of excellence. But lots of the hospitals that we would take patients to for quite serious conditions like acute abdomens or serious fractures, major trauma, we may not be happy with to treat severe COVID, because the treatment of severe COVID is so cutting edge. And it's not just about having access to monoclonal antibodies and antivirals and so on, but also that nuanced decision making in the intensive care unit that seems to make a big difference to outcomes. So severe COVID needs ultra expert care, and we need to be quite discerning about where we take those patients. So if we think about our approach to early stage COVID-19, so these are the patients who are in the first stage of the disease, they're not that unwell, they've tested positive, they're feeling ill, whatever. Our approach with these patients is that we must undertake a broad risk assessment. And there are patient factors that we need to look at. So we need to look at their past medical history and their age, of course, and identify the risks that they carry for developing severe COVID. Of course, now we have to take, part of that assessment now is vaccination status as well, because they may have been vaccinated, thereby reducing their risk. And we'll look at the severity of their current symptoms. And then there are the situational things that we have to take into account, such as what's the quality of healthcare locally? Not only what is it usually like, but has it been degraded? So if you look at India as an example, normally the healthcare in India is pretty good if you're in a big city, but lately it's been difficult because it's been overwhelmed. And the final thing we think about is how easy would it be to evacuate this individual if that's what we chose to do? And I'll come on later to why evacuations can be difficult. What all that feeds into is a decision on the need for a preemptive evacuation. We certainly don't evacuate everyone who has COVID. It would be impossible to do that. And remember, nearly everyone who gets COVID-19 is actually going to be just fine. It's only a small number of patients who are going to go on to get unwell, and it is quite easy to predict who those patients might be. So if we identify someone who's got real risks for developing severe COVID and we're worried about the local healthcare, those are the individuals whom we might evacuate. And just as an example, in the last couple of weeks, we've had about 50 of these cases in India, and we've evacuated 2 of them. So that gives you the kind of ratio that we're talking about. If we don't evacuate them, that doesn't mean that they're abandoned. In fact, there's an enormous amount that we can do. So we will give them lots and lots of advice down the phone to help them manage their symptoms. Remember, we'll give lots and lots of advice down the phone to help them manage their symptoms. Remember, these people are outpatients, they're usually in their own accommodation. Advice that they avoid transmitting the disease to other people. If they work for a company or if they've got a group of people around them, we'll liaise with them so that they get the support that they need, people to bring them food and other support, or we can use local agents to do that. And depending on where they are, we can help them minimize their risk of being incarcerated in an unhelpful sort of isolation unit or fever hospital, unless that's really necessary. And at the same time, the medical team are checking on them daily, remotely. If at all possible, we'll get them an oxygen saturation monitor so that we can see how the saturations are doing, do all the safety netting that would be done in primary care in the UK. And of course, they have access to us 24/7. If there's a problem, we tell them what to look out for. And by doing this, we will nurse people through this illness remotely, because it's a very worrying time to have COVID, especially if you're in a resource-poor area, and we will get people through it. So what I want to move on to now is talking about air ambulance evacuation. Air ambulance evacuation is terribly important because it's one of the principal mitigators of risk for those who travel to difficult locations abroad, and it's a benefit that's been there for a very long time, but since the pandemic started, it hasn't been working. And I want to describe some of the difficulties that have faced us in doing air ambulance evacuations around the world. And in fact, there are so many difficulties to talk about that one way of just breaking it down and thinking about it is to think about an air ambulance journey as having an origin, that's the resource poor location, if you like, where the patient's fallen ill, the transfer itself, and the destination. So if we start with the origin, in other words, this is the location where the person's fallen ill, there are all sorts of problems that face us. Some of them have been resolved. So in the black square, there's a description of what it was like at the beginning of the pandemic, when lots of countries were in panic stations. Sometimes many countries would just refuse to allow an air ambulance in. They wouldn't allow any aircraft in. They would refuse to release patients from fever hospitals. You couldn't get a ground ambulance to take your patient to the airfield. There were many, many problems to overcome. But as COVID became more commonplace, everybody adapted, and many of those problems went away. But it's still very, very difficult to file a flight plan. For example, filing a flight plan used to be very, very simple, and now it's time consuming for many countries. And there are all sorts of operational difficulties that make it difficult for us to send air ambulances. So for example, if you're doing a long distance air ambulance journey, the aircraft is going to fly from Europe, let's say, to somewhere in Africa. If it's a long journey, the crew, the flight crew, the pilots are going to need to rest before flying back, because there's only a limited number of hours that pilots can do. If they're not allowed in by the immigration authorities, then that means we're going to have to fly them to a third country where they stay in a hotel, and then we'll position them the next day for the return. The only other way around it is to actually put 2 pilots and 2 co-pilots on the plane. That's called doing a heavy crew, and one crew rests on the outbound, and then they fly the aircraft back. It's not ideal, because actually those crew won't be well rested, having had to sleep on the plane. And the other thing we have to consider is that the medical crew will be similarly tired at the very minute that we need them to actually be looking after the patient. So it's not ideal. The other big problem that we have is something called tarmac transfer. So normally with an air ambulance evacuation, what we would like to do is send the air ambulance to the location. Then the medical crew go to the hospital where the patient is, and then they can spend time there, putting in lines, making sure the patient is stable, having a look at all the scans, speaking to the treating doctors, making sure they've got all the notes, the blood results, you name it, everything that they need. And when everything is absolutely perfect and the patient is stable, then they can set off on the return journey. We can't usually do that now, because they won't usually allow the medical crew to leave the airfield. So instead, the patient has to be bundled into an ambulance and taken to the airport, and the air ambulance crew meet the patient for the first time on the tarmac. That's why it's called a tarmac transfer. They don't get the chance to speak to the treating doctors. Scans and notes and important things are left behind. Lines haven't been put in, and the patient might be physiologically unstable on arrival at the aircraft. And you can see why that is a very, very unsatisfactory way of doing things. If we think about the air ambulance journey itself, one problem we have is that there are fewer air ambulances around now than there used to be, because many of them are effectively grounded. And that's because they're domiciled in countries which have very strict rules on travel. An example is Australia. Australian air ambulances can't really do international missions anymore because the quarantine requirements on return are too strict. So they're just taken out of the picture. And there are many other air ambulances that we can't use for similar reasons. So we have a shortage of air ambulances globally. And then, of course, on board the air ambulance, we have to think about infection control. Not for normal patients, but if your patient has COVID, or if your patient is simply suspected of having COVID, or merely we don't have a negative test, then they're going to have to travel in an isolation device. So this is an example of a small isolator. This is called an isovac. As you can see, it's a lump of plastic, which wouldn't look out of place in a children's play center, to be honest. This is suitable for short haul journeys and really for patients who aren't that unwell. So mild COVID is okay for this thing. If it's a more severe case, or if it's going to be a longer journey, then we prefer to use this device. This is a bigger box, if you like, called an epi shuttle. And as you can see, it's much easier to see through the plastic because it's rigid plastic. The ports are a bit better. You can have a ventilated patient in an epi shuttle. So the patient goes in this and then goes in the plane. We're very lucky actually that this technology was developed actually in 2016 in the context of the Ebola crisis in West Africa, although to be honest, it wasn't really used very much, but it was great because this technology then existed when we needed it, which is for COVID. One slight problem with the isolators, especially the epi shuttle, which is the one that we prefer to use, is it won't go in small planes. The plane that you're looking at right now is a Lear 45, and Lear jets are the usual jets we would use for air ambulance evacuation. They are relatively good value, although still eye-wateringly expensive. But we can't get an epi shuttle in a Lear jet. Instead, we have to use one of these, which is a Challenger. As you can see, it's much, much larger. It is a beautiful aircraft, and it has a fantastic range and loads of space on board, but about 3 times the price of using a Learjet. So if you thought that air ambulance evacuations were grievously expensive before the pandemic, they're murderously expensive now for whoever is paying the bill. The other problem, and this is a real problem with isolation pods, is that there are quite strict dimensional limits on who can fit into a pod. They're a bit small, these pods. So, for example, there's a height limit of 190 centimeters, which in old money is 6'3". That's not that tall. We all know people who are taller than that. But the big problem actually is the width. The patient can't be wider than 60 centimeters, or they'll really struggle to fit into one of these pods. Now, width isn't a measurement that we're really that familiar with. Most people don't know their width because it's not a measurement that we give to our tailors. And in fact, it turns out it's very difficult to measure your width consistently. It's quite a difficult thing to do. But trust me, 60 centimeters is not that wide. So if your patient's a big person, they're going to struggle to get into one of these isolation pods. And we're often asked, well, why can't they just come up with a bigger pod, like a bariatric pod or something? The reason is on that picture there. It has to go through the door. That is the limiter. The thing about air ambulances is there's no such thing as a purpose-built air ambulance. There are just planes that exist, passenger planes, that have been turned into air ambulances. If you were going to design an air ambulance from scratch, you would put in a bigger door. But we have to work with the doors that exist, and that is why the pods are a bit small. So we've thought about problems, air ambulance problems at the patient's origin. We thought about the journey itself, and then there are challenges at the destination as well. I've already talked about how serious COVID-19 requires ultra expert care. And that means that we might want to take the patient a longer distance to get the patient to, let's say, Western Europe or North America, rather than going for a regional destination. But actually, lots of the regional evacuation destinations that we used to use are now closed, or they're very, very difficult to access. So, for example, normally if you had a seriously ill patient in Cambodia, you would just fly them to Bangkok. You can't now. Bangkok will not take patients from overseas, or it takes so long to get permission that it's not worth it. So we have to take patients much longer distances. And, in reality, a lot of the time patients are going back to their home country, even if it's a very, very long journey. But that does pose a problem for patients who are originally from developing countries, because they may have very few options available to them. The country that they're from may not have the medical facilities to treat them, but it can be very, very difficult to persuade a third patient to take developing country nationals, and that is a big cause of delay. I've already talked about picking up patients with the tarmac transfer. Well, sometimes we have to drop off patients with the tarmac transfer as well, and that is just as unsatisfactory as at the origin. And another big challenge is that patients, if we're evacuating a patient with mild COVID-19, on arrival, they're going to need somewhere to go. We can't admit them to hospital because they're not ill enough to go into hospital, but they're going to have to go somewhere. They need to self-isolate. If they've got their own flat or something, then that's great. But if they don't, it's quite challenging to find somewhere for them to go, because a hotel isn't going to want to look after someone who's known to have COVID-19. So you have to find an appropriate unit of accommodation for this person to see out their period of self-isolation, and that can be a lot harder than it sounds. So, in summary, medical evacuation takes much, much longer than it ever used to. Not only that, it's much more expensive now than it ever was before, because we're having to use larger aircraft and we're having to fly much longer distances with patients than we ever used to. And it's also more likely to be needed than ever before. Before the pandemic, if we had a medical case in a difficult location, we could say, well, let's just see how this patient goes, and if he deteriorates, we can always evacuate him. Now, because it takes quite a long time to evacuate patients, we have to think, okay, well, might this patient deteriorate? And if he did, would it be okay if it then took us 2 days to get there with an air ambulance? And if the answer is no, it wouldn't be okay, then we need to really think about doing an air ambulance preemptively, just in case the patient deteriorates. In other words, the threshold for air ambulance evacuation has been lowered. So if you're a bill payer, if it's your job to pay for air ambulances, there are going to be some big bills until the pandemic is concluded. There are some exceptional risks that I really want to highlight. Obviously, one is that anyone whose health is frail and who is traveling to a difficult, resource-poor location where medical care is not good, if that person's risk mitigation entirely hinges on the availability of rapid air ambulance evacuation, then the risk of that person's traveling needs to be reassessed. But in addition to that, I really want to highlight again that patients who exceed isolated pod dimensions, if they get COVID and they need to be evacuated, that can be a very, very difficult thing to carry out. That's number one. And the second thing I want to reiterate is developing country nationals. Of course, this is more for employers to think about, but if you have, let's say, a driver working for an NGO in Burundi and they're originally from Chad, and something happens to them, it could be extremely difficult to find a country with a good hospital that will take that Chadian national. In terms of risk mitigation, a lot of this actually links into the previous talk. So promotion of COVID-19 vaccination is an obvious way of dialing down risk right across the board. And certainly, I think employers who are thinking of sending staff abroad need to think carefully about their vaccination policies. In general, I'm against mandatory vaccination, but I think if you're sending someone to a resource-poor location, it's definitely something to think carefully about, especially if the individual has obvious risks for developing severe COVID. And pre-travel risk assessment is very important. Of course, travel clinics do this, but employers can do it as well. There are many schemes out there now which will provide a mathematical insight into the COVID risks that people present, because of course many people's COVID risk is extremely low, but there are individuals whose COVID risk is very significant. And if you're an employer, you may find that nearly all of your COVID risk is sitting with a relatively small number of people. So if you can identify those people, it allows you to make the appropriate interventions to ensure that their travel is safer, or indeed you might not want them to travel at all. And finally, both individuals and organizations need to inquire, I think, more deeply into what insurance and assistance services are available to them before they travel, and make sure that they're with an insurance company or an assistance company that understands the way that travel risk has changed, and in particular that expensive air ambulance evacuations are sometimes needed for patients who aren't yet unwell, but who it is feared might deteriorate, because that's something that's really changed. So on that, I think I'll stop, and I think next we'll enter the Q&A session. Thank you.